now we're going to talk about common surgical swellings which you encounter in your routine clinical practice, and as interns you must have seen multiple such cases. Also, because we are getting ready for the next exam where the exam is going to be more clinically oriented, I also want to include case discussions here which are not only going to benefit final year students who are preparing for their college exams, but it will also help you in understanding how to solve clinical questions in the next exam. So let's start with the clinical case, and then I'm going to discuss all these swellings in detail along with their theory. So we have a 56-year-old female who has come to us with a scalp swelling since the last 4 years, right? So that is the duration of the swelling. It's been there since the last 4 years. There is gradual increase in size of the swelling and it is painless. Patient gives a history of thick whitish discharge coming from the swelling occasionally. Okay, this is very important. We'll discuss why this is important. There is no history of intense pain, redness associated with the swelling. So why are we taking this history? So always remember, whenever you're taking a history, there has to be some positive history points and there have to be some negative history points as well. When you're presenting a case, for me as an examiner, the negative history is as important as the positive history which you've elicited. Okay. So why have I taken this history? This is to rule out inflammation or infection in that swelling. Okay. There is no history of headache. Why is that point important? Because there is a swelling over the scalp. If there is pressure over the brain matter, there can be a headache. So this is to rule out intracranial extension. There are no other swellings over the rest of the body. Why is that important for us? Because neurofibromatosis, you can have multiple neurofibromas or there can be multiple lipomas all over the body. That is known as Derkham's disease. So again, there is a single swelling, no other swelling over the rest of the body. So these are all negative history points. Other things, no swellings in the neck. Now you know that scalp is draining to the cervical lymph nodes also. So no swellings in the neck is to rule out lymph nodes. Why am I telling you all these in detail? Because as final year students, you should know why you're taking that negative history. Okay. There are no comorbid conditions. Patient finished her chemotherapy for ovarian cancer 3 months back. So this is a significant thing again. She's had ovarian cancer treatment for which she's finished her chemotherapy recently. She was diagnosed 9 months back and also underwent a surgery for the same. Right? This is also important. Maybe this swelling can be associated with her ovarian cancer history. Let's see. There's no family history of cancer and she is non-vegetarian. Okay. Now, once our history is done, the examiner, for final year students, the examiner asks you, what is the impression of your case? What do you infer from this case? So what I infer is a 56-year-old lady with a painless scalp swelling, since 4 years, and there is a recent history of ovarian cancer treatment. Right? So this is my summary of the case. This is the summary which you have to complete in 2 lines when the examiner asks you. Now, examination, always remember that don't have a tunnel vision of just examining that swelling. You should examine the patient holistically. Entire patient has to be examined. Okay. So on examination, the lady is well nourished, well hydrated. She's a middle-aged lady with an average build. You should take the vitals in the exam because a lot of times students say vitals stable, right? They don't actually measure them, but they have fallen prey to the examiner's wrath in these situations because sometimes, the examiner knows that the patient might be an undiagnosed hypertensive patient and you have not taken the vitals. that can be problematic for you. So always measure the vitals. The general physical examination is normal. Now you can see the swelling here. I have recorded actual examination videos which will help you in assessing what the swelling looks like and what are the various tests which we have done. So let me just play the video of the examination for you and demonstrate to you some important clinical signs which were there in this case. So in this first video, you can see that the skin over the swelling cannot be pinched. Now that is very important. If the skin over the swelling cannot be pinched, means the swelling is arising from the skin itself. If it was some swelling which was below the skin, then you could have pinched the skin overlying the swelling. In the next video, you can see that I have demonstrated fluctuation, and I have very clearly written that fluctuation should always be done in 2 axes, right? To confirm whether it's true fluctuation or not, you should always do fluctuation in 2 axes in any swelling. So to discuss the clinical findings with you, when you have to describe the case to the examiner, you will say that post-chemotherapy alopecia was present. You could see that there was sparse hair there. And there was a 3 into 2 centimeter swelling in the occipital region. There was no ulceration, dilated veins, punctum, signs of inflammation over the swelling. You could not see a punctum, right? And there were no signs of inflammation over that swelling as well. No cuff impulse was present. Why is that important in such a swelling? Because if the swelling is over the scalp, cuff impulse again is for intracranial extension. We need to do this. There were no other swellings visible on the scalp. Okay. The swelling also, one more thing which you should know, that no transillumination was there. If it was a meningocele, then transillumination will be present. No transillumination here. On palpation, the swelling was non-tender, firm, well-defined margins were there. Fluctuation I demonstrated to you, it was present, skin could not be pinched, and it was a non-compressible swelling. Again, if it's a meningocele which is communicating with the brain inside, that can be compressible. No palpable lymphadenopathy in the cervical region. Okay. So this is your clinical examination. Then again, you'll do a systemic examination as well. Except for the midline laparotomy scar for her ovarian cancer surgery, no other significant findings were there. Now, once you finish this, once you finish the history and physical examination, again, your examiner is now going to ask you what are your differential diagnosis. Okay, what is the differential? So, this is really important for you to understand how to come to differentials and how to support your differential diagnosis. Now, I've written down 3 differential diagnoses here. We've written down a sebaceous cyst, a basal cell carcinoma over the scalp, which is also common area, and whether is it related to ovarian cancer or not. And for every differential diagnosis, you have to say points in favor and points against, right? You have to say points in favor of that diagnosis, points against that diagnosis. Now, if you look at a sebaceous cyst, history, it is a 4-year-long history, can be there in a sebaceous cyst. A very important point in favor of a sebaceous cyst is whitish discharge coming from the swelling. So this is point in favor, a strong point in favor of a sebaceous cyst. So these are the points in history for a sebaceous cyst. What are the points in examination? Scalp is a common site. You can get multiple sebaceous cysts as well. But a point against a sebaceous cyst is that the classical punctum is not seen, which is a strong point against it. But again, a strong point in favor of a sebaceous cyst is that skin cannot be pinched and fluctuation is present. So skin cannot be pinched means it is arising from the skin, and you know sebaceous cyst is a blocked hair follicle duct. It is going to arise from the skin itself. Okay. Basal cell carcinoma. Now, basal cell carcinoma History, yes, it's a long history, but if it was such a long history, there would have been local invasion as well. There would have been increase in size. All those things are not there in this patient. Scalp is a common sign. There is no ulceration, which is a point against, and the skin cannot be pinched. That means it's arising from the skin, so that is slightly in favor of it being a basal cell carcinoma, but other points are against it. Now, is it related to ovarian cancer? Swelling was present even before the diagnosis of ovarian cancer. Ovarian cancer was 9 months back. This has been there for the last 4 years, so not related to ovarian cancer, right? So this is how you defend your differential diagnosis. Then your examiner is going to ask you how to proceed. Now, whenever the examiner asks you how to proceed, just don't start rattling that, I'll do FNAC, I'll do this, I'll do that. You should always say, I will do investigations to confirm the diagnosis. I will do investigations to support my diagnosis, and I'll do investigations to treat the patient. Okay. So, which investigation will confirm the diagnosis for us? FNAC, fine needle aspiration cytology. This we know, we've discussed previously. It is a needle test, 23 to 30 gauge needle. It can confirm your diagnosis. To support the diagnosis, I would also need one more thing in this patient, very important. I would like to do an X-ray of the skull. Right? This is my precaution before surgery, an X-ray of the skull. Why is this X-ray done? To make sure that there is no intracranial extension, to rule out intracranial extension. Right? That is why we do an X-ray. On FNAC, it turned out to be a sebaceous cyst, and we carried out an excision of the sebaceous cyst, right? So, I will be covering more such clinical cases in the relevant modules. This is not only important for final years, but also for those who are preparing for the next exam. So, please don't skip these clinical case discussions. They are important for you. Now that we've discussed this case, let's move on to common swellings which we have to discuss. The first one is a sebaceous cyst. Like we've just discussed, sebaceous cyst is a blocked hair follicle. It is a blocked hair follicle duct which can give rise to a cyst. Cyst is because it is fluid filled. It has this thick whitish content inside it which is almost paste-like, and that can come out sometimes. You look at this image, this whitish content is coming out. This is another classical point for a sebaceous cyst which I told you, which you can elicit in history as well. And when we talk about a sebaceous cyst on examination, because it is a cyst, it will be fluctuant. There will be a punctum which will be present. So punctum is going to be present. It is a classical feature. But even if the punctum is not there, it can still be a sebaceous cyst. Look here, please. Look at the punctum. This is the punctum which is present. Now, sebaceous cysts are usually painless unless they are inflamed. And skin cannot be pinched. Skin cannot be pinched because it is arising from the skin only. You cannot pinch the skin overlying the swelling. What are the complications of a sebaceous cyst? Again, this you can see is an image of a sebaceous cyst. You can see the classical punctum here. This is the punctum which you can see. The complications are that the cyst can become inflamed. This is an inflamed sebaceous cyst. You can see the punctum here, and you can see that pus has started forming. So this is an inflamed sebaceous cyst. You can also have multiple sebaceous cysts, and multiple sebaceous cysts, the common site are the scrotum and the scalp. Right? Scrotum and scalp, multiple sebaceous cysts can form. You can see these multiple sebaceous cysts in the scrotum. Another question which are asked in your Viva is, two places in the body where sebaceous cyst cannot occur. Where sebaceous cyst cannot occur. So any place where there are no hair follicles, sebaceous cyst will not occur. And what are those places? Palms and sole. Right? So no hair follicles here, so you can't have sebaceous cyst. And the management of a sebaceous cyst is excision. We have to excise the cyst completely so that it does not recur. So this is regarding sebaceous cyst, which you should know about. Another common swelling is a dermoid cyst. Again, most of the swellings which I'm talking about here are in the head and neck region. That's the common place where you're going to get a clinical case in the exam. You'll get a head and neck swelling only. So dermoid cyst, you know, it occurs when epithelial elements get entrapped. When epithelial elements get entrapped along lines of embryonic fusion. That is when a dermoid cyst can occur, right? So these epithelial elements get entrapped and a cyst is formed. It is lined by epithelium. It is lined by epithelium. Sometimes there can be, sometimes a tuft of hair can be there. A tuft of hair can be present over the swelling. But what is the classical point for a dermoid cyst? It will be along lines of embryonic fusion. It will be along lines of embryonic fusion. So the classical areas for a dermoid cyst are the outer canthus of the eye. As you can see here. Or it can be a post-auricular dermoid. This one is a post-auricular dermoid. So again, what will be the points in clinical examination which you need to know about? So clinical examination, it is a cyst. So again, we've discussed if it is a cyst, any fluid-filled structure fluctuation will be present. Right? And this is not arising from the skin, so skin can be pinched over it. Skin can be pinched over the swelling. Very important, we have to rule out intracranial extension. Always rule out intracranial extension, so look for a cuff impulse. In these patients, always look for a cuff impulse in these patients as well. The management of dermoid cyst is excision, but as I've told you, excision should only be done once you've ruled out an intracranial extension. So this is a very important question which is asked in the Viva. Without ruling out intracranial extension, never do surgery for a dermoid cyst. Another type of dermoid is an implantation dermoid. Implantation dermoid can develop after trauma. And the most common is after ear piercing. After ear piercing, you can have a swelling like this developing on the back of the ear. This is an implantation dermoid which needs to be excised. Another very common swelling is a lipoma. Lipoma is in fact the most common benign soft tissue swelling. It is the most common benign soft tissue swelling. It is nothing but an accumulation of fat, and important thing is that it is encapsulated. So it has a capsule around it. It is encapsulated. It can be present anywhere in the body, And lipoma, again, it is arising from the subcutaneous tissue. It is arising from the subcutaneous tissue. So on examination, skin can be pinched. Because it is not arising from the skin, skin can be pinched over it. Okay. Very important. Classical is slip sign is present over a lipoma. This has been asked in the exam. So slip sign is, you can see here, if I press on the edge, if I press on the edge of the lipoma, it is going to slip under my finger. The swelling slips under my finger. That is slip sign. It is classical for a lipoma. Pseudo fluctuation can be present. Sometimes the fat is of such a consistency that pseudo fluctuation can be present, which is why I told you true fluctuation you need to perform in 2 axes. Okay. So these are the points in clinical examination which you should know. Now lipomas, again the diagnosis can be confirmed by FNAC. Even for a dermoid cyst, the diagnosis is confirmed on FNAC. So you can confirm the diagnosis on FNAC, and the management is surgery. Do we remove all lipomas? No. Only remove if there is rapid increase in size, if there is pain, that means it's impinging on some nerve, if it is a cosmetic problem. So those are the indications when we should remove a lipoma. All lipomas do not need removal. Another term which you should know is Dercum's disease. Now Dercum's disease is multiple lipomas or lipomatosis. And you will get a young male or a female who will come to your OPD and they'll be disturbed. They'll say that I have 50 or 100 swellings all over my body. And what should I do? I'm about to get married. You tell me some solution for these swellings. Unfortunately, there is no medication, nor is there a surgical solution to remove all the swellings. And these swellings can increase in number as the years progress. But they are benign condition, nothing to worry about. A differential diagnosis here is neurofibromatosis. So to rule it out, in the first sitting, you can do an FNAC from one of the swelling, and that can differentiate the 2 conditions. Another point which you should know is that lipomas in the retroperitoneum, lipomas in retroperitoneum and thigh have a tendency to undergo malignant change, have tendency for sarcomatous change, which can occur. They can form into a liposarcoma, which is the most common sarcoma you know. So it can undergo a sarcomatous change as well. So this is regarding a lipoma. The next swelling. So when you remove a lipoma, this is what it looks like. It is well encapsulated, comprises of fat. The next head and neck swelling you should know about is a cystic hygroma. So cystic hygroma is also known as a lymphangioma. It is also known as a lymphangioma, and it is nothing but sequestered lymphatic tissue. It is nothing but sequestered lymphatic tissue which gets sequestered during embryogenesis. Okay. The most common site as you can see in the image here is the neck, and that too the posterior triangle of the neck. Other sites where a cystic hygroma can occur, other sites are axilla and inguinal region. Now, what are the clinical features or the various presentations of a cystic hygroma? So, a cystic hygroma, as you know, is a cyst cystic swelling. So again fluctuation will be present. It has clear fluid inside it. It is a cystic swelling, has clear fluid. Now because there is clear fluid, which sign can you elicit here? Yes, correct. You can do transillumination. So transillumination is present. In fact, it is one of the brilliantly transilluminant swellings in the body. So cystic hygroma, ranula, which I am going to cover next, and an epididymal cyst and hydrocele, these are all brilliantly transilluminant swellings because they have clear fluid inside them. This is partly compressible. This is partly compressible. Now in the hernia module, I've explained to you what is the difference between compressibility and reducibility. Compressibility is I can press it and it will go inside. But as soon as I remove pressure, it will fill up on its own. Without any counter pressure, it will fill up on its own. That is compressibility. So lymphangiomas can be partly compressible. Again, skin can be pinched because it is not arising from the skin. Now, what are the presentations of a cystic hygroma? So, it can be detected in utero. In utero, scans can pick up cystic hygromas. In fact, it is one of the soft markers for chromosomal abnormalities. It is a soft marker for chromosomal abnormality if you detect it in a scan in utero. Now, it can sometimes become so big that it can cause obstructed labor. This swelling can be so big that obstructed labor can occur. Then it can become infected. Infection can occur. It can rupture. So these are all complications of a cystic hygroma which you should know about. The diagnosis is confirmed by FNAC, which is fine needle aspiration cytology, and the management of these patients. The first line management of a cystic hygroma is aspiration plus sclerotherapy. There is a specific agent which is used for sclerotherapy that is known as picibanil. But the definitive treatment, if it does not respond to the first line treatment, the definitive treatment is surgery. One thing which I want you to know, which has been asked in the MCQ exam as well, that if you are removing a cystic hygroma, which is there in the posterior triangle of the neck, if you are doing excision for this, which nerve can be injured here? So posterior triangle cystic hygroma, which nerve can be injured? Spinal accessory nerve injury can occur. So we need to be careful while excising such a cystic hygroma. So this was regarding cystic hygromas. It is a very common short note for final year students. So the next swelling which we need to talk about is a ranula. Now this I've covered even in the salivary gland module. But for the sake of completion, ranula is a mucus extravasation cyst. It is a mucus extravasation cyst involving the sublingual salivary gland. Mind you, it is a mucus extravasation cyst, not a mucus retention cyst. So make sure ranula is mucus extravasation. And it is a fluctuant swelling. It is a fluctuant cystic swelling in the floor of the mouth. And the literal meaning of ranula is a frog's belly, right? So this is a ranula. You can see here it's a cystic swelling in the floor of the mouth. And because it is cystic, it is fluctuant. And because it has clear fluid inside it, it is brilliantly transilluminant as well. It is brilliantly transilluminant. Now the diagnosis of ranula, although it's a clinical diagnosis, for the sake of completion and FNAC can be done, and the management of a ranula is surgery. Now what is the surgery which is done for a ranula? Surgery can either be excision of the cyst, it can be excision of cyst plus sublingual salivary gland, or we can do marsupialization, or we can carry out marsupialization. Please remember that incision and drainage is contraindicated. IND is contraindicated. This is very important for you to understand. Incision and drainage is not done for a ranula. We can either do excision of cyst plus sublingual gland or marsupialization. Now, what is the difference between incision and drainage and marsupialization? Let me just explain that to you. So, supposing this is the roof of the ranula, right? This is the roof. This one is the roof of the ranula. If I just incise it, if I just open it up like this, this is incision and drainage, right? But what is going to happen? That this area would heal up again and the ranula will form again. So there is a very, very high recurrence rate if you just do an incision and drainage. What is marsupialization now? Marsupialization is when I'm going to incise this, these two edges which are formed, I'm going to suture them on the side. So I'm going to suture these two edges on the side. So what is going to happen? The mouth is going to remain open. And if the mouth remains open, the ranula is not going to recur. So that is marsupialization, when we suture the two edges on the side so that the mouth remains open. Two questions which have been asked here. The most common structure injured. This is an important MCQ. Most common structure injured during ranula surgery is the submandibular gland duct. But the most common nerve injured during ranula surgery is the lingual nerve. So these two MCQs you should remember. Another term which you should remember is a plunging ranula. So a plunging ranula is a mucus retention cyst. Ranula was mucus extravasation. Plunging ranula is a mucus retention cyst involving sublingual and submandibular salivary gland. Involving the sublingual and the submandibular gland. So the patient is now going to have a swelling in the oral cavity and a swelling in the neck. So there's going to be a swelling in the oral cavity and in the neck. Oral plus neck swelling is going to be there, right? The management of a plunging ranula is excision of the oral swelling, plus sublingual gland, like we were doing for a ranula, plus aspiration of neck swelling, plus aspiration of the neck swelling. So that is the management of a plunging ranula. You should know about that as well. Now, because I told you about a submandibular swelling, there is one very important clinical point which I want to tell you here. Now, if you have a swelling in the submandibular triangle, it can either be the gland or it can be the lymph node. So, how do we differentiate? How to differentiate between submandibular gland enlargement, submandibular gland versus lymph node enlargement? This question is asked not only in your practical exams but also as an MCQ. So to differentiate this, we do bimanual palpation. Bimanual palpation means 2 fingers inside the oral cavity, 2 fingers in the neck, and then we palpate. Submandibular gland is bimanually palpable because you know the submandibular gland has a deep lobe as well, which is bimanually palpable. Lymph node is not bimanually palpable. So that is how we can differentiate the two. This is a classical parotid swelling. You know, a parotid swelling, the hallmark is that it is going to lift the ear lobule, right? So you will have a swelling which lifts the ear lobule. That is a classical finding of a parotid swelling. Another clinical point which I want to discuss here in a parotid swelling is how to know if deep lobe of parotid is involved. So this was asked in the DNB exam and the FMG exam. I think so it's a very good question. They had asked clinically, how do we know that the deep lobe of parotid is also involved? So for that, we ask the patient to open his mouth and we see if tonsillar fossa is pushed medially. If the tonsillar fossa is pushed medially, then the deep lobe of parotid is also involved. Another soft indicator can be involvement of facial nerve. Can also be a soft indicator, but if tonsillar fossa is pushed medially, that means the deep lobe is also involved. Another neck swelling which you should know about is a thyroglossal cyst. Thyroid swellings I have covered in that module. In the thyroid module, even a thyroglossal cyst I have covered there. But again, I'll just mention the important points here. A thyroglossal cyst is nothing but a remnant of the thyroglossal tract. The details you can see in the thyroid module. How does it develop? So it is a remnant of the thyroglossal tract. And this swelling, the most common location of this swelling has been asked so many times in the exam. It is subhyoid. It is below the hyoid bone in the midline. So it is a midline neck swelling. Subhyoid location is the most common location for a thyroglossal cyst. Now, because tract is attached to base of tongue, because the tract is attached to the base of tongue, a thyroglossal cyst moves with deglutition. But what is so special if it moves with deglutition? Even a thyroid swelling moves with deglutition. The special thing is it moves with protrusion of tongue as well. It moves with protrusion of tongue as well. If you ask the patient to protrude his or her tongue, the swelling will also move. But make sure that when you're doing this test, when you're eliciting this sign, you support the head of the patient. The patient should not be moving his or her head up and down like this. That would give you false findings. The diagnosis is confirmed by FNAC, and the management, it is very important. It is not incision and drainage. Again, incision and drainage is not done. We do cyst trunk surgery. Cyst trunk procedure is removal of cyst, plus the tract till base of tongue, plus part of hyoid bone. Please remember, part of hyoid bone also has to be removed. Then only complete excision will be attained. Otherwise, you cannot excise it completely. If IND is done, if somebody does an IND by mistake, a thyroglossal fistula is formed. And the management of a thyroglossal fistula also remains the same. It is cyst trunk surgery. This question has also been asked in the MCQ exam. And long-standing cysts, which thyroid cancer can develop in long-standing cysts? Papillary thyroid cancer can develop. This question has also been asked in the All India exam. So long-standing cysts, papillary thyroid cancer can develop. Another next swelling is a branchial cyst, right? You know that branchial cyst, this has been covered in ENT by Dr. Manisha as well. A branchial cyst is nothing but a persistent cervical sinus. It is a persistent cervical sinus. You know that the second arch grows and it fuses with the sixth arch, and this cervical sinus which is formed, it obliterates. If it fails to obliterate, if it persists, then it forms a branchial cyst. And this is a cystic swelling. It is a cystic swelling which is again transilluminant, and it is seen in the neck. Where do we see it? Anterior border of sternocleidomastoid. Anterior border of sternocleidomastoid, and the cervical sinus, or the cervical sinus which is persisting and forming a branchial cyst, is at the junction of upper and middle 1/3. Is at the junction of upper and middle 1/3. Diagnosis is by FNAC and the management is excision. Now you can also have a branchial fistula. On this side is a branchial fistula. Branchial fistula, when will it develop? When the second arch fails to fuse with the sixth arch. If there is non-fusion of the second arch with the sixth arch, then a branchial fistula will form. And this is also along the anterior border of SCM, sternocleidomastoid. But this is at the junction of middle and lower 1/3. So please remember this difference, that a cyst was upper and middle 1/3, whereas a fistula is middle and lower 1/3, right? The management remains the same. The management is also excision of this cyst. So this you can see is a typical branchial cyst which you can see here. One final swelling which I want to cover in the head and neck region, which is very important for your exam, is cervical lymphadenopathy. Now cervical lymphadenopathy is also a very common short case which you get in your college exams. Now cervical lymphadenopathy, the levels of cervical lymph nodes I have covered in the oral cancer module. So you can see the levels there. The most common cause of cervical lymphadenopathy in India is tuberculosis. So that's what we're going to talk about. We are going to talk about tubercular cervical lymphadenopathy. Now tubercular cervical lymphadenopathy, the most common lymph node group involved is level 2. This is according to the latest Bailey, it is level 2. Earlier they used to say it is the posterior triangle or level 5. Now what happens in cervical lymphadenopathy is that this is the deep fascia, this greenish is the deep fascia, and below this we have our lymph nodes. So when the tubercular infection occurs, you know which necrosis occurs? Caseous necrosis occurs. Caseous necrosis occurs in the lymph nodes, and the wall of the lymph node also becomes inflamed. So the wall also becomes inflamed, and this wall or the surrounding area inflammation is known as periadenitis. This is known as periadenitis. So because of periadenitis, when the wall is sticky or inflamed, these lymph nodes get stuck to each other. And when these lymph nodes get stuck to each other, that is known as matting, right? That is known as matting of these lymph nodes. which occurs due to periadenitis. This is matting of lymph nodes. Then what is going to happen, that in these lymph nodes, pus is going to form. So in these lymph nodes, pus forms. So ultimately, you will get one big coalesced mass of lymph nodes which has pus inside it. So there is pus inside this lymph node mass. Now what is going to happen in the next step, that this lymph node mass will make a small opening for itself in the fascia. Right, so a small opening is formed and you have an abscess cavity below and you have an abscess cavity above that fascia. Okay. So this is pus and you have an abscess cavity below the fascia and above the fascia and a small opening in the fascia. This gives rise to the typical collar stud abscess, which is seen in the neck in tuberculosis. This is a cold abscess. Why are tubercular abscesses known as cold abscesses? Because they don't exhibit signs of inflammation. They don't exhibit signs of inflammation. That is why it is a cold abscess. But a cold abscess in the neck is known as a collar stud abscess. Very important question. Now, you get a patient who is 8 or 9 years old. He's come with this neck lymph node mass, and your pediatrics professor or surgery professor asks you, how are you going to confirm the diagnosis? So you tell the examiner that I'm going to do aspiration and AFB staining of the pus. Right, I'll look for acid-fast bacilli. The examiner says, fine, but how will you aspirate this swelling? That is the most important thing. So what you need to remember is that always anti-gravity aspiration should be done. Anti-gravity or non-dependent aspiration from above, anti-gravity or non-dependent aspiration for tubercular cervical lymph nodes. Why? Why? Because if I do a dependent aspiration, then this tract will not heal and it will form into a fistula. If you do dependent, that pus will keep on trickling down, it will not heal and a fistula will form. So anti-gravity aspiration and AFB staining is what is going to clinch your diagnosis, and then you have to start the patient on ATT. So this covers the module on common surgical swellings, and the first case which I've discussed, I've told you how to approach a patient with a swelling and how to defend your differential diagnosis. Thank you.